Warning, incoming transmission.
My involvement in chronic fatigue syndrome started in 1989, 19 years ago now, when as an osteopath, specialising more in sports injuries, I had a patient that came in who previously was a cyclist. And he told me he's got postural problems and he had back problems, that's why he came to me. But he also mentioned that for 7 years he had chronic fatigue syndrome, ME. And in those days I thought, well, there's nothing much I can do for that. In the 1980s we all, thought it was just psychosomatic and tender loving care, smile at the patient and it might help them. But I had no concept that I could help this person from his chronic fatigue, but I could definitely help his postural mechanics. And I started treating him, and lo and behold, after a few months, he started significantly improving, and eventually he, within the few months I treated him, he said his symptoms have disappeared. I've cured him. I said, no, nonsense. How can I help you? So he said, no, you have, and he was the one that started me all those years ago in my search for why I managed to help this patient and what was going on. So we start with the thoracic spine because he had thoracic spinal problems, and in my paper of 1993 in the British Osteopathic Journal I looked at the common findings in patients with associated symptoms. I had quite a few patients with these ME type symptoms, and I wasn't somebody to diagnose ME, but I noticed that they had all the same problems. Their thoracic spine was visibly not posturally the way it should be. It should be curved in the middle and what we call slightly kyphosis. And they were often flattening and distortion, as you'll see. This is a healthy spine, and you can see here how it curves out and then inwards there, what we call a lordosis, and a kyphosis and lordosis, which goes inwards. And we see an ME patient where there's definitely a flattening, and this picture was taken in 1989, 1990, this patient, many years ago. And equally we had patients who had very rigid spines, especially the elderly ones, so they had definite visible problems in their thoracic spine. Very, very clear flattening and then outside. And we saw problems affecting not just the back of their postural mechanics, but also the very front. And you can see here how her sternum is completely concave there, putting terrible pressure on the mechanics of a thorax. And what we saw in many, many cases was what we call osteochondrosis or Sherman's, where the flattened area and this area of the spine should go in and it goes out quite often. And this is again and again and again. In the hundreds of patients, over 1,000 patients I've seen since 1989, they all have major problems that you can see in the spine. They might not have pain. Not all of them have pain associated with it, but most of them do. And in fact, most of them have a lot of tenderness in the mid-thoracic area. And I thought, well, what's going on? How can this be? And nobody actually had looked at the mechanical ME, CFS from a biomechanical perspective. And I suggested that at that time, the centre of the sympathetic nervous system, which you've heard about this morning, part of the autonomic nervous system, centres at the thoracic spine. From T1 to L2, there's two chains of sympathetic nerves that spread out throughout the body. And I thought, well, possibly, mechanically, these patients are over-irritating the sympathetics, which is causing all the symptoms of ME. And ME, basically, if you look at all the symptoms, it's symptoms of sympathetic nervous system disarray. Again, this is another patient with it, and then sometimes you had some patients where you could actually see some spinal abnormalities if you did an MR scan. And over here you can see in the spinal cord there's a syrinx in this patient, a swelling, a cyst in a spinal cord. Same patient has a Chiari malformation, which is the bottom of the cerebellum in the brain actually dips slightly into the foramen magnum of the spinal cord. And this is an abnormality that has been noted by Dr. David Ho in America, and has done research into this area of Chiari malformation leading to chronic fatigue syndrome. But we looked at the brain of this patient, and the brain was there's no problems at all with the brain. It's a perfectly healthy brain. If you did a standard MR scan, and part of my research later on at Manchester University was looking at MR scanning of patients, and we noted that the standard MR scanning that you'd be sent by your GP to, not the extra ones that you've seen, the spectrography or the functional MRI or the SPECT scans, but the standard MRI scans don't show up any major abnormality. And we did a long test. We had 18 patients who went through before a year of scanning, compared to 9 healthy people, and we showed this is a research done at Manchester University in a few years ago now, where we showed there was no abnormality that we could see in the standard MR scanning, which is very significant because a lot of patients might be sent by by doctors for MR scanning, and they'll say, well, can't find anything wrong with you, there's nothing wrong there. But it doesn't have to show, you need specialised scanning. But let's go back to the sympathetic nervous system. This is a nervous system that was always believed to be very much an efferent system, sending messages out to different organs, causing changes in blood flow to organs and changes in not just blood flow, but you've got changes in sweat glands and changes in all sorts of parts of the body, and the heart rate changes. This sympathetic nerve, as we've heard this morning, is affected. But there's a Professor Frank Willard in New England who has done a lot of extensive anatomy into the sympathetic nervous system, and he's shown that 70 to 80% of all sympathetic nerves are afferent, actually send messages to the hypothalamus rather than from the hypothalamus, because it's the hypothalamus which is the major problem area. As you've heard before, the hypothalamic pituitary axis is involved in virtually everybody's studies, and we know this goes wrong. But why? What's going on? What mechanism is causing this to happen? Why do some patients get ME and some not? You've heard suggestions today. I've with my extensive clinical treatment of patients and the research I've done at Salford University and Manchester, I've come up with a hypothesis. An hypothesis based on the fact that, have you heard today, that there are some parts of the brain that there's no blood-brain barrier? You heard this morning. The hypothalamus has a very weakened blood-brain barrier as well. Why? Because besides controlling the autonomic nervous system, the sympathetic and parasympathetic, it also controls the hormones. And how does it control hormones? It controls it by a mechanism called biofeedback mechanism. Hormones enter, which are large protein molecules, enter the hypothalamus, and the hypothalamus then sends messages to the body changing as it sees fit. And this is the crucial fact in why we know that large protein molecules are able to enter at the hypothalamus. And I'll come back to that very shortly. Why do we need a lymphatic system? Well, there's the clue. In the body we have the blood that drains toxins, and the blood capillaries drain toxins through a mechanism called filtration. Small molecules will enter the capillary membrane and go up the blood eventually to the liver and detoxify. But what happens to the large molecules, the nasties, the cytokines, as we've heard, lymphokines, cytokines, there's prostaglandins, there's lots of inflammatory toxins and infectious toxins that are too large for the body to cope with, the blood to cope with. So how does the body help? We have the lymphatic system. Large protein molecules enter the terminal lymphatics, which are the capillaries of the lymphatics, and they enter through these almost like a gill, as you see there. It doesn't matter how large the molecule is, it goes into the lymphatics. The lymphatics then will drain on the way, will stop off at lymph nodes until it gets to as it goes up the lymph vessels, and there's one directional flow, there's valves stopping any backflow, and eventually it ends up into the thoracic duct area in the left side, as you'll see in a minute. And also it ends up, eventually through the thoracic duct, it goes into the blood, into the left subclavian vein. Some of it goes into the right subclavian vein through the right lymphatic duct, and eventually ends up in the bloodstream, where it can be readily, after being broken down in the lymphatic system, it can be readily broken down in the liver. This is why we have a lymphatic system, because of the size of molecules. So the question is asked, and the question was actually asked in this university many years ago, and it's quite apt that I'm here doing this lecture now, because of Professor Weller and Professor Roy Weller, who some of you might know, if you're from the university here, and together with Professor Helen Sir from America, who unfortunately died of a brain tumour when she was only 59. But he did work with her that showed there was a drainage of the brain to the lymphatic system. And it's crucial to my hypothesis. So I'm very privileged to be here in the same area as Roy Weller did his research. What they found, and as you've heard today from Hugh, that the perivascular spaces are very crucial to the drainage. There's cerebrospinal fluid drains in the perivascular spaces, down and into the lymphatic system. And this was shown very aptly by Kida, Pantazis and Weller in 1993, when they showed it in a rat, where they actually injected into the rat, and they saw through the cribriform plate, the olfactory nerves also have blood vessels, and the perivascular space around those blood vessels allow this drainage pathway into the lymphatic system in the cervical lymph nodes, and into the facial lymph nodes, eventually into the cervical lymph nodes. And this is very crucial part, because if this doesn't work properly, you get a build-up of toxicity in the brain. The brain has to have a way of draining out these large protein molecules, and that's why I said go back to the hypothalamus. Large protein molecules can enter the brain through the hypothalamus because there's no major blood brain barrier. So large toxins as well as the hormones can enter, and as you've heard before, that there are other ventriculatory organs that are in the brain, that those organs themselves have no blood-brain barrier either. So the blood-brain barrier, even if it's perfectly intact, there's still damage from toxins as well. But we know that in everybody there's an opening. So these large protein molecules get into the brain. They have to be drained away somehow. There's no true lymphatic system in the central nervous system. We have to have another system, and this is it. What Weller and his co-workers discovered. And this drainage pathway is in the human as well. We don't just have the olfactory nerves where there's a pathway through the cribriform plate. There's also through the perivascular spaces around the optic nerve, around the trigeminal nerve, and around the auditory nerve. And this could relate to a lot of the symptoms that ME patients get, with pressure in this area, pressure behind their eyes, tenderness, tinnitus, as we've heard, in the ears, and soreness and pressure in their mouths. And as you'll see later on, there's other signs, physical signs, of toxicity coming out through the skin because it's not able to drain off. So this is the cribriform plate. This is a bird's eye view of the plate. You take out the brain, you can see the perforations there which allow the nerves to drain, the olfactory nerves to go through, the olfactory bulb. But you've also got blood vessels and you've got cerebrospinal fluid draining through this area. And this is not new. The founder of osteopathy, Dr. Andrew Taylor Still, 100 years ago or more, talked about the waters of the brain draining into the lymphatics. How he knew that, I do not know. It was a theory, but he was right. And it goes into this thoracic duct. Now, the thoracic duct is very interesting. Most of you have learnt anatomy and physiology if you're doctors, and you will have learnt that in the early days, anyway, it might be it's changing now, that the lymphatics don't have a pump of their own. That the movement of the lymphatics is through blood vessels and muscles around the lymph. That's how I was taught when I was studying. And this is how most of medicine is taught. And it's just plainly not true. The lymphatic system does have a pump of its own, and it's in the thoracic duct. The thoracic duct has smooth muscle walls that slowly pumps the lymph out into the blood vessels. And it was discovered by Professor John Kinmont, that guy is in St Thomas's Medical School. And that's he wrote a book, The Lymphatics. He did work with Browse to show that it was the sympathetic nerves that were causing this conduction, this peristaltic wave up into the blood vessels. And it's this research that I put them both together to come up with my hypothesis. Because what's happened is there's a backflow. Kinmont said in many diseases there's a backflow. This in the sympathetic nervous system doesn't work properly, it goes into disarray, and it causes smooth muscle wall contractility to go completely wrong. It then pushes some of the lymph back into the lymphatic system, affecting the unidirectional valves of the lymph vessels, which then become varicose. Now, he mentioned the varicose lymphatics, and he said that they become engorged and enlarged, and you can actually see them on scans. He did lymphangiograms, but the trouble is that most people who saw it said, well, it's just veins you're showing in scans. It proves that they're lymph. So we could never absolutely 100% prove it, although it is mentioned in the books. A few years ago, I had the luck or the fate that a patient came in where we could actually see it, absolute see it, and he visibly shown it. And this is the subclavian region, this is the clavicle, that's the armpit, and you can see these are very, if we go back to that diagram there, and you see there quite clearly the varicose lymphatics. Now, if you actually enlarge it, you can see it more clearly. And how do we know they're lymphatics? I'll just show you that this is where the collapsed valves are. But how do we know that they're not veins? Normally, remember, normally lymphatics wouldn't be visible at all. They'd be so minute, the diameter, and they wouldn't be visible at all. But this is definitely visible, and we definitely know it's a lymphatic vessel. Does anybody know how we know? Colourless, exactly. If they were blood vessels, if there were veins, they'd have blood in them. They'd be blue, they'd be purplish. These are the same colour because lymph contains a white fluid. In fact, the old name for lymphatic vessels was lacteals. So they used to think it was like a milky white fluid. So it would be the same colour as the skin. And you can see the same on the other side. You can see quite clearly. Now this is very, very rare to actually see it. I was looking for this for years, and we actually found it. But you can feel it in every ME sufferer. The physical finding, as an osteopath, I'm physically examining the patients as well as taking a full case history, and we are looking at the physical signs. We are feeling the body, and when we feel the body, we can feel this in every single one of the patients I've seen with ME. They have these varicose lymphatic, these very, very palpable vessels that are tortuous and bulbous and sort of beaded-like. So the theory is as follows. ME starts by a problem in the head and the spine together. If you just had a problem in the drainage of the head, the spine can still, the jaw lymphatics, the perivascular spaces down the spine can still drain off the large toxins that are coming into the brain from infections or heavy metal poisoning. And Professor Hooper's done a lot of work on different on vaccines and how and Gulf War syndrome, all these terrible toxins entering the brain. Now in a healthy, there's 60,000 toxins that can affect the human body. Every year chemical companies are producing another 1,000. So we're not talking about one or two, we're talking about thousands of toxins that should drain off from the brain and the spinal cord, but aren't. And it's not just the head or the spine, it's both. So what we see in all ME sufferers is problems in the head that we can actually feel and sometimes see, and problems in the spine that we can mostly see. If that happens, then there's going to be a build-up of toxins. All the toxins aren't going to drain away. It's going to start affecting the nervous system, and especially the hypothalamus. From external stimuli to internal stimuli going to hit the hypothalamus via the limbic system, good stress and bad stress. And we heard from Brian about how marriage can be a bit of bad stress sometimes, and but hopefully it's only good stress. But it's still stressful, and via the limbic system it's going to affect the hypothalamus big time. The hormonal system is going to affect the hypothalamus, and this is these are the two reasons why I feel women get ME much more than men. There probably is a genetic predisposition as well, which obviously hopefully Esty will actually look in more into. But the hormonal system and the hormonal system is obviously much more complex in women. And every month, and you'll find clinically, and the clinicians here will know, clinically, premenstrually and menstrual cycles have a major role in the symptoms of ME. And they do, a lot of patients go really downhill premenstrually. And again, it's the breast tissue as well. The breast tissue is where the main drainage of the lymph will actually push backwards, and the women's breast tissue is obviously much more enhanced than men. So we have the sympathetic nervous system overloading, and we've heard this morning how that can happen. The sympathetic nervous system then breaks down, And then eventually you get a reduction of blood flow into the organs, and the lymphatic drainage is affected, as you now know from Kinmont's work, the lymphatic drainage is then pumping the wrong way, which causes further toxins in the body and into the build-up of brain and spine. And it's very interesting that this pathway, this drainage pathway, is both ways. And you heard this morning about the study done in America, Nevada, showing that cancer, brain tumours, and it actually looked at lymphomas, but also they showed that brain tumours were high up, were raised up in some of the ME patients they were looking at as well, or post-Epstein-Barr. So it can run both ways. I'm not saying that you will end up with brain tumours, God forbid, but the worst case scenario of toxicity in a brain can obviously lead to brain tumours. Further damage to the sympathetic nervous system via the hypothalamus, which causes a worsening lymphatic drainage, which causes further toxic build-up, and this vicious circle I believe we call ME. So these are the signs that physically I feel in every single patient I see with ME, and if most of them have been diagnosed by hospitals before they've come to me via the CDC criteria for CUDA. And you see the varicose lymphatics that we have. We also have a point which was coined by a patient, Perrin's point, so it's stuck. It's lateral to the left nipple about 1 inch or so, or 2 centimetres, and is slightly superior. And every ME sufferer that I've examined has this tender point. And the reason for, and the more severe the ME, usually the more tenderness. And the reason I've come up with is that we know the thoracic duct goes to the left side and up to the subclavian area. And that we know now has sympathetic nerves. Now the sympathetic nerves lie alongside somatic nerves, sensory nerves, and they're firing off. They cross over. There's crossover of the two nerves, of the nerve axons in areas called epapses. And this is in the books if you want to look it up. And then there's crossover of these sympathetic nerves to the somatics, and it causes a lot of irritation in this area. At the same time, you've got the cardiac plexus, and the heart is very much infected by, and the blood vessels to the heart are very much affected by ME. And that cardiac plexus would cause, again, via crossover to sensory nerves, will cause another large area of sensitivity in this area. Where they cross over seems to be this point here, Perrin's point. There's also, if patients have bowel problems, have irritable bowel or irritable bladder, or lots of aches and pains in their legs, and that's often their case, the celiac plexus, which is the big bundle of sympathetic nerves, also known as the solar plexus, that's very tender. And we see this again and again. It's almost a litmus test to anything below. Any symptoms below this area, fire up this celiac plexus. And we know already, as I've said, that there's spinal problems. And then there's the least known of within orthodox medicine is the cranial rhythm. You might have heard of cranial osteopathy, and it works on this cranial rhythm. And I've written a research paper in the American. It was published in June in the American Journal of American Osteopathic Association, which goes to 35,000 doctors, because American osteopaths are qualified medical practitioners as well. And they published this paper showing that the cranial rhythmic impulse is actually this drainage. It's a drainage of the head. It's the reduction of cerebrospinal fluid that is produced by the heart, by the blood. So the heart rate, the 50 to 100 beats per minute, is transmitted through the cerebrospinal fluid. It then drains off to the thoracic duct that Kinmont and Browse worked out was 4 beats per minute. You have 2 waves that create a third wave, and it's this third palpable wave that we're feeling. And with ME sufferers, this wave, this cranial rhythmic impulse, is definitely down. We see this in every single patient. It doesn't mean that the rate changes. It feels, I describe it as feeling like a deflated football rather than an inflated balloon. And we can feel this. It's palpable for people who have trained in this field, can feel it. And these are the physical signs that we see in all ME sufferers.
Raymond,